Mike Gibson, Gregg Stone coming to you live from SCAI 2016. Greg, give us an update or state of the art on BVS. Where are we?
Well, you know, Mike, it's been an exciting time for bioresorbable scaffolds. It was only about 6 weeks ago that we actually presented the data from Absorb 3 to the FDA Advisory Board panel. And of course, you know, the trial was powered for non-inferiority at 1 year. It had met its endpoints, and the Advisory Board panel voted 9-0 that it was safe and effective for the indicated purposes.
Greg, when do you think we're going to hear from the FDA itself?
Well, you know, the latest we're hearing is actually around July.
Great.
That's what Abbott's saying, so I feel comfortable saying it because they're saying that. So, you know, July would be great. With a 9-0 vote, you know, that's a pretty strong mandate that we should get it out. But that being said, there were some important insights into the data that we discussed. You know, while the device looks very effective, it's got very similar restenosis rates, both clinical and angiographic compared to Xience, you know, there were some trends towards greater device thrombosis and greater target vessel myocardial infarction.
Sure.
And we really think we've been able to identify that that's because of implantation in very small vessels. Vessels less than 2.5 millimeters, which is the really smallest that it was intended for. We saw that in Absorb 3. A large group in Europe also saw that in an unrestricted use population. And so we're working out the labeling with the FDA as to how to best educate people on this and avoid implanting it in less than 2.5 millimeter vessels. So of course you can use online QCA, you can use intravascular ultrasound or OCT imaging, but what should trigger the mandatory or strongly recommended use of making sure you don't have a small vessel?
And do you think there's going to be anything in the instructions for use that's going to specify
I think there will be. I think there will be.
To size?
Yeah, I think there will be. And I mean, any of those three we think are fine, QCA, OCT, or IVUS, but the question is what should trigger that recommendation? I don't think it's going to be mandatory, but I think it's going to be a strong recommendation. So should it be if you are considering using a 2.5 scaffold, or should it be if you think you've got a vessel that's maybe 2.75 or smaller? Use imaging, and every lab has online QCA. We don't do it much in the US, but in Europe, they do it frequently. It's very simple. It takes you know, a minute or two. You know, just QCA the vessel, make sure it's really 2.5 or larger. Because you know, Absorb, you know, it's a thicker strut, it's a wider strut, and you know, compared to metallic drug-eluting stents, it has a bigger footprint, a surface area to coverage ratio. And if you take that and then you squeeze it into a really small vessel, you could have up to 40% or so of the surface area coverage with a big, thick polymer, and then there's a certain encroachment in the lumen, so you have a lot of turbulence, a little blood flow, platelet activation and deposition, thrombosis. But I think if you use it as directed, you know, for right now, and you know, really 2.5 to 4.0 vessels, you know, 1, perhaps 2. We really don't have much experience with overlapping yet in our trials. Then you can get very similar 1-year results with Absorb as with Xience, and then hopefully have all the other benefits emerge over time of restoring underlying coronary physiology, vascular adaptive responses, et cetera.
And in terms of implantation technique, you know, this runs counter to our ADD as interventional cardiologists, right? So what work needs to be done there?
So, you know, that's really important because the metallic drug-eluting stents have gotten so good that we can get away with being sloppy, to be very honest with you. And people often direct stent, and then they may or may not post-dilate.
I don't. I just go
and
to
they
very
don't
high
use imaging very often. And again, you get away with it most of the time, although I do think we can do even better with metallic drug-eluting stents by paying really good attention to technique. But with this first-in-class device, Absorb BVS, it is important. So we're actually going to teach a technique that we call PSP. PSP. It's simple. It's pre-dilatation, size appropriately, post-dilatation. So we think you should pre-dilate every lesion, and we actually recommend pretty aggressive pre-dilatation. So near 1-to-1 pre-dilatation, even with non-compliant balloons, and kind of liberal use of scoring, cutting balloons, and or atherectomy is necessary. Then implant the device. We don't want the device to do the work.
Can I ask you a question, Greg, about the length of the device? You know, we were taught with DES go normal to normal. You know, with bare metal stents, we're a little tighter, a little longer with DS. What's the recommendation with
pretty
the BVS?
much similar to DS.
Yeah,
You want
normal to normal.
Yeah, normal to normal. You know, you want to make sure that you really have the disease covered to the edges. You don't want edge dissections or significant inflow or outflow stenosis. So the concept of aggressive predilatation is then you basically just deliver the device at 10 atmospheres. You don't want the device to have to do the work of opening up the lesion. Basically, you're just delivering it, inflating it, and getting rid of it. Then put in a non-compliant balloon sized, you know, or with a length within the BVS margins, and then crank it up. And no more than 0.5 millimeters larger than the scaffold size you put in. You'll never fracture it. You can take it up to 30 atmospheres. You won't hurt it. You know, as long as you
that's really that
absolutely
high. Wow.
You can take it up to 50 atmospheres.
Wow.
As long as you don't oversize it, the pressure doesn't hurt the scaffold.
And you're not doing anything to the polymer with those kinds of pressures, really?
Absolutely not.
Interesting.
Yeah. So we recommend 20 atmospheres. 20. I mean, when I think of high pressure, just 20 atmospheres. Just, you know, crank it up. Non-compliant balloon, though, you know, that won't grow more than, you know, a 0.2, 0.3 millimeters, even at any pressure. And then you're done. You know, I think it's good for people to use imaging, especially at the beginning, to see the differences in the way the vessel accepts the polymeric device as opposed to a metal stent. But I think if you follow the simple PSP and are pretty aggressive with sizing, you know, again, the Europeans have shown that you can get stent thrombosis rates in kind of an all-comer population down to what you would expect with a metal DES, but you have to be aggressive with sizing and your post-dilatation techniques.
And when are we going to have some more definitive information about restoring vascular health and the late results? When can we start to see some of that?
Well, you know, the at TCT this year, we're actually expecting the primary endpoint results from Absorb 2 to be presented, which actually was 3-year vasomotion.
Oh, cool.
So that ought to be very interesting because, you know, one, it was a large study, relatively, for a vasomotion type study, 500 patients. 2, by 3 years, the device is gone. So we're seeing really normal vessel now looking at vasomotion at 3 years.
Is it vasomotion right in the stented segment or throughout the entire vessel? Both. Interesting.
Exactly. So they'll be looking at both and reporting both. So, you know, we don't yet have the correlation between normal vasomotion and long-term clinical outcomes, and hopefully that will come over time. We know that normal vascular health leads to nitric oxide production, important for endothelial health, et cetera, et cetera. It should correlate, but we need that link. And then finally, the real look towards long-term superiority is going to come from Absorb 4, which is a total of 5,000 randomized patients, which is powered for superiority between 1 and 5 years with Absorb compared to Science. But that's not going to be available till probably 2022.
Wow.
So hopefully, if you and I are still sitting at this podium, then we're going to be kind of
It'll be a lot shorter, but we'll have some data.
But you know, it actually, you know, it'll come before you know it. I mean, this everything's moving so fast.
Great.
So that's where we're
exciting
at.
Field.
It is.
Thanks for leading it. Thanks for joining us here today, Greg.
My pleasure.
And thanks to all of you for joining us here live from SCAI 2016.